started, we had only not more than 100 pediatric endocrinologists in the country, and the burden was huge. So there were thousands of cases of pediatric endocrinology were there, but then there were very few to cater them. So what we thought that there was a need somehow to have bridge in between them to develop special interest in pediatricians and physicians, and then they can really match and manage the overall case. Since then, there have been definite improvements which have happened, and now so many new things have happened. But this was what when I started in 2007 in that regards. So we started off and we realized that awareness was a major problem. So whenever we talk of a disorder, we know that there are three things: awareness, accessibility, and affordability. Now, everybody says it's affordability, especially when it comes to hormones. They're expensive, were difficult to get, but it's actually awareness. So we started with pediatricians' awareness. This was in 2012, and we can see many of the people who are still there. Many of the faculty is the same from that time. It's continuing from there. And then we conducted a number of programs across the country. We developed 6 modules, which are still the base of many of our courses. Till now, we have conducted 120 workshops, 15 practical pediatric endocrine courses across the country, and 5 advanced pediatric endocrine symposium. This is the 6th one that we conducted. So this was the first one in 2017, and we can see Dr. Hemchand here. So he was there right away at that point of time. Again, Dr. Hemchand talked about bone age. We discussed about this. Then there was a couple of year gap because of COVID. Since then, we have been having annual events every year. Every time we have got very good people coming from across the country. Now, after conducting so many programs, what we realize that once you conduct the program, people forget about that. Whatever you teach, they will just don't remember. And it is too much effort to go in terms of money, in terms of time, manpower, and everything. So we thought of using the power of social media to highlight that. We set up this channel, which is now one of the largest channels as far as pediatric endocrinology is concerned. And it has been viewed across the globe. It provides, there are over 400 videos and everything on pediatric endocrinology. So anything and everything, it's available there. We then thought of in terms of systematic approach in terms of pediatric endocrinology learning. So we started off with our fellowship program in 2017. And as Dr. Ravindra was saying, that we are now recognized by the National Board of Examination. And it was in fact a dream for the last 10, 15 years that we were pushing for pediatric endocrinology fellowships, which were not available from NB. And now finally the dream has come, and BJ Vadia and our center is now the 2 centers which are going to provide training in pediatric endocrinology. Now, what we realize that even physical fellowships, many people who have done training and who are in practice or doing some medical education, they are unable to really come in for 2 years because it's very difficult for them to join and leave the practice. So we started with online learning in terms of medi classes followed by books. And then we thought if you want to empower people to develop applications so that they can use, and we discussed some of the innovations just recently. Our fellowship started in 2017, and both of them are here. Dr. Neha and Dr. Chetan, they started with the first program. Dr. Riddhi and Dr. Sajali was also there in the second group. Dr. Pratik is currently in UK. Dr. Sayan and Dr. Naveen are now pursuing DM courses in PGI Chandigarh and at AIMS Delhi. Dr. Manoj was here. As we can see, Dr. Vibha has joined with us as a consultant. Dhwani is currently in Patna, so we have people across the country. And we have got Dr. Alapan and Sandeep who are still there, who are working. And Dr. Nimisha is the last one to join. So we've got 13 people who have joined, and hopefully very soon we will have the National Board Accredited Fellowship, which will start here. Our learning portal provides validated tools for evaluation, assessment, and pediatric endocrinology, including a full fellowship in pediatric endocrinology. So we launched around 3 years ago, fellowship program in pediatric endocrinology, which was a very, I would say, a tough program. It has 2-year learning. Every 2 months, there are online exams. There are continuously lectures every week. Every 6 months, there is a 5 days program in which they come, they see a lot of patients, we discuss with them, and then this program happens. So there are 4 sessions which are there. We have developed a mobile application, which in fact is the most downloaded endocrinology app, and we talked about publications there. We are developing other tools like personalized intelligent EMR, which will help guide evaluation and management of pediatric endocrine disorders. We have developed BIG, the bone age assisted interpretation of growth, which recently Dr. Vibha was just talking about how it will help assess puberty, growth, bone age, and obesity at one single click. You will be able to get all the results. We are developing a personalized expert for nutrition in which it will analyze all your meal items in terms of lot of input which we don't know about glycemic load, all the other aspects, and then it will also provide based upon the requirement the recommended 7-day allowance. So automatic diet chart will come in for patients, which is coming up. We have already developed the Diabuddy app, which provides insulin dose guidance based upon glucose as well as carbohydrate counting, which is there inbuilt in the app, and this is being validated right away. So hopefully next time we would be launching it in a proper for a general use in that perspective. We have got number of books, basic, pediatric, and advanced. So we have tried to do a lot in this area over the last decade or so. Many of our efforts have been recognized. As I showed, Dr. Riddhi won the award for Best Bone Age Presentation at Kolkata, Dr. Sayan for Puberty Interpreter, Dr. Alapan at APES, Dr. Dhwani won the Kaichi Kida Award for the DSD Interpreter, Bone Age Assisted Interpretation for Growth, Dr. Vibha. Then also, so all of presentations have been there. There are a number of publications coming out of our tools which have been validated and developed. So our fellowship in pediatric endocrinology, as I said, is a comprehensive one. There are over 100 modules, approximately 1,000 hours of videos that people have to watch. Pre-test, post-test, live lectures are there. There are on-site 4 visits with hands-on exposure. Assessments are done bi-monthly, 6-monthly, and an exit exam. And then there are other opportunities to collaborate in terms of research, learning, and teaching. So we have had multiple, we have now 9 on-site courses. This happens every 6 months. Started from 2019. To date, we have had all these on-site courses, and we can see many of the places which are here also. So this was the last course which was done just in June 25. And all of them, I think most of them are here. And this was the extensive program in which we had 300 patients coming from growth, puberty, thyroid, electrolyte, all the disorders. And they were discussed in intensive fashion. And discussion was there. So till now, 48 people have been awarded fellowships in this program. Ongoing 72 people are doing fellowship. There are many other courses also where people are enrolled. That number goes to thousands or something. 12 nationalities have been enrolled on that. So this is a way in which we are trying to increase the number of people who are working towards pediatric endocrinology. 3 major aspects: impaired PTH effect, increased PTH effect, and low bone mass. We had a wonderful discussion yesterday. Dr. Hemchand talked about how to assess bone density, correct it for height, correct it for bone age and other parameters. So we'll try to talk those things forward. So impaired PTH effect, of course, is an important endocrine cause of hypocalcemia. It can be because of a problem in PTH, which may be genetic. Now, there are multiple disorders. We won't go into precisely those disorders. It can be syndromic. And one thing which you should remember is DiGeorge syndrome, which is extremely important from that perspective. So DiGeorge syndrome would be something which is there to be looked into, especially if you have a young child who presents to us with impaired PTH effect. In that regards, DiGeorge syndrome becomes an important differential from that perspective. Later onset in the childhood, the first possibility will be autoimmune, APS1, and we discussed about immune endocrinopathy a lot yesterday. Then there could be a problem in the sensing of calcium. The classical example is the calcium sensing receptor defect, in which you have hypocalcemia with hypercalciuria. Body thinks that there's a lot of calcium in the body. So that condition would be there. And then you can have a PTH resistance. Very rare is Bloom-Strand, a lethal disorder. More commonly, pseudo-hypoparathyroidism with multiple endocrine abnormalities and other rarer forms in that regards. Now, in impaired PTH effect, the hallmark is hypocalcemia with high phosphorus. So everybody who has hypocalcemia should have low phosphorus. If your phosphorus is high, that is the impaired PTH effect which is there. You should also have a normal creatinine, magnesium, and vitamin D. So before you label somebody as a PTH problem, look at vitamin D, creatinine, and magnesium before you make that diagnosis in that regards. They can present to you with coarse skin, problems in teeth, hair problems, intracranial calcification. Most neurologists that refer to us with hypocalcemia also actually do that when they find an intracranial calcification in that regards. Cataract, intracranial hypertension, and increased bone mass may be there. Very importantly, we expect that if the calcium level is low, PTH should be sky high. at least above 70. So if your calcium is low and PTH is high, this is a pseudo hypoparathyroidism or a secondary hyperparathyroidism. But if PTH is less than 70, that is normal PTH, you have to think of hypoparathyroidism as a possibility. So we are talking about high phosphorus, normal creatinine. Then we are talking about a PTH problem. And there, if PTH is low and you exclude hypomagnesemia as an important cause, do a urinary calcium. If it is high, it is a calcium sensing receptor defect. If it's normal, it is hypoparathyroidism. While if the PTH levels are high, it is most likely pseudo hypoparathyroidism. Always do vitamin D levels before diagnosing PHP because vitamin D deficiency can induce secondary resistance to PTH. And in that regard, if the AHO phenotype is not there, this is probably 1B. If it is there, do a cyclic AMP response, which is a theoretical test to look at from that perspective. Now, management, we had a big discussion today about whether PTH is better or calcitriol is better. But generally speaking, we'll talk about calcium 30 to 50 milligram per kg per day and giving calcitriol around 15 to 30 nanogram per kg per day. And we have to worry about that there will be a risk of hypercalciuria in the setting of hypoparathyroidism. Pseudo hypoparathyroidism, the PTH effect on the kidneys is preserved. So this hypercalciuria usually does not occur. And the options are clearly in the form of PTH from that perspective, which are there. And as I said, PHP, we are not that much worried about those scenarios from that perspective. So what are our targets? For hypoparathyroidism, we want the calcium on the low normal range. Don't want to keep it very high. So what we need to understand is that PHP, we are worried more of skeletal problems. Hypercalciuria is rare. So we can keep it at the higher level, 9.5 to 10. While hypoparathyroidism, we are worried about hypercalciuria. We don't want the calcium to go up 8.5 to 9. One unique condition is a calcium sensing receptor defect, which Dr. Manisha did mention about, that if you have that, you will have hypercalciuria at a very, very low level. So in that case, you want the calcium levels to be much low and maybe consider PTH right at the beginning in those cases because they will develop hypercalciuria, whatever you do. So in that perspective, we'll now start with the scenarios.
Thank you, sir. So we have the first case. It's a 4-year-old girl. She had tetany and the ionic calcium was 3.1 milligram per deciliter. The phosphorus was on the higher side, 8.4. PTH was 130 and she was labeled as pseudo hypoparathyroidism. So my question is to Dr. Vijay, what will be the approach, sir?
Yeah. So that is for sure that this child is having tetany with very low ionic calcium level. And you have mentioned that phosphate level is high and PTH is also high. So before labeling pseudo hypoparathyroidism, I would like to see other parameters, what Dr. Anurag has already told you, that what is the status of kidney. So I would like to see the creatinine level, and now you have pointed out that it is a high creatinine condition along with hyperphosphatemia. So before labeling this will be probably a case of CKD which is turning like this type of thing. So that is really very important to understand.
Thank you, sir. As rightly brought out by you, we should always look for creatinine before labeling as pseudo hypoparathyroidism. So renal failure is the important cause of creatinine with high phosphorus, and we should always do a serum creat before labeling for pseudo hypoparathyroidism. So next case, 3-month-old girl, she had seizures. Ionic calcium was 3.2 milligram per deciliter. Phosphorus was 2.2, low. PTH was very low, 3.4. And she was labeled as hypoparathyroidism. So Dr. Hemchand sir, what is your say?
I think serum phosphorus is an important game changer in the assessment of children who have hypocalcemia. Children who have parathyroid hormone deficiency usually have an elevated phosphorus level, and children who have vitamin D deficiency or vitamin D axis related disorders have a low phosphorus. In the setting of the laboratory assays, a low phosphorus puts the card more in favor of a vitamin D related axis related disorder rather than the PTH axis. I would take this PTH with a pinch of salt and look at pre-analytical and laboratory related issues to look at whether something is causing an artifact and influencing the PTH report. So this case highlights the importance of a close association with the lab, discussion with the lab technicians on the proper tube to collect a PTH sample, the importance of maintaining the temperature while transporting it, and the benefit of having an in-house laboratory to measure PTH to arrive at a proper diagnosis. In this child, this was probably related to an incorrect collection sample and transfer to the lab. So the PTH was probably repeated in another center and it was found to be elevated. So I think a low vitamin D matches well with a low phosphorus rather than a low PTH.
I think this is very common when we send the PTH to a collection center, or people take it from home and then they don't even freeze it. They just send it right away. The PTH will invariably be low. So whenever you are sending a PTH, send to the hospital rather than taking the sample at home or at a collection center, because it should be done immediately. Very, very important point. Otherwise, the diagnosis will be really confusing, as PTH is highly thermolabile.
So as correctly brought out, low phosphorus is against hypoparathyroidism, and being PTH being a thermolabile has to be collected in ice and has to be processed immediately. So next question, 7 years old girl with tetany, calcium is low 5.4, phosphorus is 7.7, creat is 0.8, PTH is low, which is 15, which is low normal.
So Dr. Manoj, the PTH is normal actually. So what do you think?
If you wish to diagnose PTH issue, then you don't have to see the calcium, you have to see the phosphorus, as Hemchand sir has told. Here the phosphorus is very high with the hypocalcemia. So that means it is directing towards the PTH defect. And what is the PTH? It is in normal range, but here normal is abnormal. So here we have to see in the context. So here I would say the diagnosis would be most likely hypoparathyroidism, because the PTH is not elevated in comparison to the hypocalcemia and the hyperphosphatemia.
Thank you very much, sir. So it's a case of hypoparathyroidism, and we should always interpret PTH with the context of calcium levels. Normal PTH with normal calcium suggests hypoparathyroidism.
So PTH should at least be 70. So when we say if FT4 is low, TSH should be more than 20. If the cortisol is low, ACTH should be more than 200. If calcium is low, PTH should be above 70. Always interpret. If there is hypoglycemia, insulin should be indetectable. So endocrinology is all about contextual evaluation. That is important.
1 week old boy had seizures, ionic calcium is low 2.4, phosphorus is 9.1, creat is normal 0.3, PTH is very low. So Dr. Viva?
If we look the case scenario here, the phosphate is high and calcium is low, and PTH is also low. Creatinine biochemical picture goes in the favor of hypoparathyroidism, but this is very early presentation. We have to think some genetic causes those present very early, because it couldn't be due to any like autoimmune or a vitamin A deficiency. So as you have mentioned that the in the this echo, it presented with the truncus arteriosus. So definitely it is a presentation of D. Georgi. And it is said that if you have this defect in the calcium, that also go for the X-ray to look for the thymic shadow, to look for the echo, to look any cardiac abnormality, because it is we miss it and we look the calcium only, and we can miss this major pathology.
And the TLC was also very, very low in this case. And this is a very, very difficult scenario. In fact, this child presented with sepsis, and it was very difficult to salvage this child because of severe infection. So hypocalcemia may be the only suggestion that this could be a DiGeorge syndrome in this scenario.
So DiGeorge syndrome, it is an early onset hypoparathyroidism. A cardiac evaluation and immune assessment has to be done. 3-year-old boy had seizures. Ionic calcium is 3.1 milligram per deciliter. Phosphorus is high, 7.8. Creat is 0.5. And this is the clinical picture of oral cavity. PTH is low. So Dr. Hemchand sir, what is your diagnosis based on the clinical and lab parameters?
I think the writing is on the wall. You're looking at a symptomatic hypocalcemia and an inappropriate rise in the phosphorus, pinning the cause on PTH, which is matching with the low PTH, inappropriately normal PTH, I would say, for the degree of hypocalcemia. And hypoparathyroidism is a tip of the iceberg. The underlying cause for hypoparathyroidism has to be thought of in the interest of the long-term health of the child. And here the vital clue is the presence of mucocutaneous candidiasis, which the onset is early, and this hypoparathyroidism puts the diagnosis of a polyendocrine syndrome on the cards highly likely. So this thought process is very important to initiate, because you really have so many things to look forward in the future in terms of evolution of children to develop transaminitis, to develop adrenal insufficiency, to develop gut related problems, etc. So I think the diagnosis which I would like to consider is an autoimmune polyendocrine syndrome, and I would like to look into this child further for any other associations which is described usually in this particular syndrome as depicted here.
I think the very important differences that are there in terms of hypoparathyroid management here compared to a classical case of idiopathic is that they require much higher doses of calcitriol because malabsorption is pretty common. And this candidiasis is not a benign thing. You have to keep on treating it, otherwise they will develop oral hairy leukoplakia, resulting in malignancy later on in that perspective. And of course, the one thing which we are always worried about, the elephant in the house, will be adrenal insufficiency, which will happen in most cases by around 5 to 10, according to me, but this mentions 10 to 20 years. This is based upon overall studies.
So on follow-up, the patient was labeled as APS1. Patient had abdominal pain, polyuria, and high calcium. Calcium was gradually tapered and then stopped. Patient presently have normal calcium. So Dr. Vijay, he was managed with calcitriol. So what could have been the reason for his stopping of calcium?
Yeah, thank you. Because this was the patient who was presented with the initially this hypocalcemia and other things, and we have started. Apart from that, since we are talking about immune endocrinopathy, that is multiple APS, autoimmune polyglandular syndrome. So in this syndrome, what is going to happen that all the things what we know that they are not going to present at the same time. So it is very important we have to be very vigilant that evolving endocrinopathy. So I would like to see that whether the patient is now developing, apart from candidiasis and hypoparathyroidism, whether Addison's disease, that is cortisol deficiency. So the first thing that we have to look for electrolytes and cortisol level, and correctly pointed out, so cortisol bit low. So what I am expecting that this patient is going to have has evolved now this cortisol deficiency too.
So cortisol is basically a hypocalcemic hormone. If you have cortisol deficiency, hypercalcemia will happen. So if you have hypoparathyroidism plus adrenal insufficiency, hypocalcemia plus hypercalcemia becomes 0. So this is a very nicely pointed out by Dr. Vijay in that regards.
On follow-up, this patient was on calcium 30 mg per kg, calcitriol 30 nanogram per kg per day. Calcium levels were 9.8 mg per deciliter. Urine calcium creatine ratio was 0.4 mg per mg. Ultrasound was a history of nephrocalcinosis.
So what will you do, Dr. Vijay, in this case?
So obviously the culprit that we have to now reduce the calcitriol, as well as probably for a short time we can stop calcium or we can reduce the dose of calcium. So and we have to follow up.
Yeah. So the target level, you think it's much higher than what
yes.
we want in this case. Yeah.
And also thiazides were started due to hypercalciuria.
This may be a point at which PTH may be considered, that if you have fluctuating course nephrocalcinosis already there, renal dysfunction already there, we may consider PTH. The one case in which we started PTH was in adult who had a very fluctuating course that was not improving at all. So it has role in certain reserved situations.
So this was case of APS1 with hypoparathyroidism and cortisol deficiency. We should always consider APS1 as a case in which a child had hypoparathyroidism in childhood. Mucocutaneous candidiasis gives a clue. It's the early presentation. Hypercalcemia usually due to the simultaneous manifestation of adrenal insufficiency. and we should set a low calcium target to prevent hypercalciuria and nephrocalcinosis.
So just a message that if you have a clear-cut case of neonatal hypoparathyroidism, this consider discharge unless proven otherwise. If you have a acquired hypoparathyroidism, consider APS1 unless proven otherwise. Which diagnostic test will give you a clue for APS1?
So APS1, we have interferon antibodies, sir, which are diagnostic.
So these are the very highly sensitive specific
Yes.
for the diagnosis there.
Thank you, sir. Next case, 10 years old boy had seizures, low ionic calcium 3.1 milligram per deciliter. This is the clinical picture of that child. He had cataract and there are subcutaneous lesions and MRI suggestive of multiple calcification. CT suggestive of multiple calcification in the brain parenchyma. So Dr. Manoj?
Yeah. So here a case is speaking by itself. Here we have a hypocalcemia with a subcapsular cataract, subcutaneous calcification in the MRI in the basal ganglia. You are seeing the calcification. So this is the case of the hypoparathyroidism with the ectopic calcification. Now we have to see what kind of the hypoparathyroidism it is. It is a pseudo or is it true? So first of all, here the phosphorus is a mainstay that is guiding towards the hypoparathyroidism. We have to do the creatinine, but in this favor pseudo hypoparathyroidism is looking more prominent here. I would like to know the value of the PTH.
This patient also had brachymetacarpia.
Yeah.
The PTH level was 200.
Yeah, so it is guiding us towards our diagnosis of the hypoparathyroidism, and the brachymetacarpia is the main pathognomic features for the pseudo hypoparathyroidism and the Turner syndrome.
Very importantly for PHP, the features are milder because the PTH is acting through multiple pathways, not just the cyclic AMP pathway. In PHP, only that pathway is affected. So PHP is always milder, does not usually present very early. So if you have an early onset hypocalcemia with hyperphosphatemia, there are other causes, not PHP. This is the most common type of presentation, mildish hypercalcemia, hypocalcemia, but calcification will be very, very prominent here. What other endocrine investigations you will consider, Dr. Manoj, in this case?
So here they might associated with the TSH resistance. So we have to do the thyroid profile. In some case of the pseudohypothyroidism, they do have an abnormality in terms of the pituitary also. So we have to look for the obesity, TSH resistance, and the pituitary hormonal abnormality. And skeletal dysplasia also main the some present in some of the cases. So we have to rule out it.
So Dr. Hemche, do you have experience of severe obesity with pseudohypoparathyroidism?
I think, no, sir.
Okay, so we have had, and that is a very interesting presentation. So sometimes they may present, so 1-year-old child presented with hyperphagia, rapid weight gain, mildly elevated TSH. So people thought it is hypothyroidism, but TSH was like 8. And then calcium, everything was normal, only PTH was elevated. So this could be a presentation because the MC4R also acts with the GNAS pathway. So they behave like that. And theoretically, they may respond to set melanocytes. So this is something which is known. And we always say short stature with obesity, hypothyroidism, pseudo hypoparathyroidism becomes a differential Cushing. So that is there, but they may present with early onset. Calcium may be normal. So don't just rely that calcium is normal in the first year. Does not mean that this cannot be PHP.
So the calcium targets, we can set a normal calcium
So
target.
Dr. Manoj, what will be the calcium target?
Yeah, here PTH effect is preserved in the kidney perspective. So here if we want to target the calcium, then it would be little bit higher than the hypoparathyroidism because there will be no nephrocalcinosis unless and until we are giving with a very higher dose.
Thank you, sir. So this was a case of pseudo hypoparathyroidism, hypocalcemia with high phosphorus. They have round faces and other clinical manifestations like brachymetacarpia. We can set a higher calcium targets than hypoparathyroidism because the PTH effect is preserved on the kidneys.
And in fact, sometimes they present to us with query refractory rickets-like presentation also because the PTH is increasing the calcium resorption. There, if you maintain calcium around 9.5, they will resolve very quickly. So again, PHP is a masquerader which will be there. Hypocalcemia with high phosphorus, rickets with high phosphorus. Two things where PHP should be considered. Now we'll move forward quickly towards the increased PTH effect, which basically is most commonly because of hyperparathyroidism, which can be isolated. More importantly, because of the calcium sensing receptor defect, in which you have hypercalcemia with hypocalciuria, the opposite. So the body is not sensing calcium. Older children, men associations, typically men one in the second decade of life, very rare. And then you can have sporadic hyperparathyroidism. There could also be a sensing defect, which we discussed, and very rarely sensitization. So the major problem within the parathyroid, unlike pseudo-hypoparathyroidism, others are rare. McEwen-Albright syndrome can sometimes cause hypercalcemia. So when should you suspect hypercalcemia? Sick neonate with dehydration, anybody with polyuria, hypotonia, encephalopathy, calcium should be done. Abdominal pain in older children. So we all talk about moan, groan, and body pain. So these are the typical manifestation for adults with hyperparathyroidism. So abdominal pain, hypertension because of calcium effect, and ectopic calcification. Metabolic bone disease or bone resorption can also be there. So again, we are thinking of hypercalcemia with hypophosphatemia. So PTH is high. Very importantly, most patients who are referred to us with hyperparathyroidism are secondary. They are not primary, and sometimes it may cause confusion. You should have a normal creatinine, vitamin D, and rule out treated hypophosphatemic rickets. Again, I said that if the calcium levels are high, PTH should be undetectable. So if your PTH is more than 20 in somebody with hypercalcemia, that means it is hyperparathyroidism. While if the PTH is normal, this could be a calcium sensing receptor defect. So when we talk about hypercalcemia, PTH below 20, PTH above 20, we have to think of these things. PTH below 20, vitamin D related causes. So we are talking about this arm. Then you look at the fractional excretion of calcium. If it's more than 2%, this is classically hyperparathyroidism. If it is less than 1%, look at vitamin D, because vitamin D deficiency may mask your hypercalciuria. If vitamin D is normal and yet you are not excreting, this is familiar hypercalcemic hypocalciuria. While if it is in between, again, you give a course of vitamin D. Now, most cases that we see have a normal calcium, low phosphorus, high PTH, and a low level of urinary calcium. In that case, if vitamin D is low, you give a course, small dose of vitamin D for a month or two, and then see what happens to the calcium and PTH, and your diagnosis will be made. So this is something which is very, very important from that perspective. Now, what should be done? So, of course, if it is a adenoma, in most cases you can do a resection. But remember, in young individuals below the age of 30 years, multifocality is common. So getting a scan and seeing one adenoma removing may not be the true. You have to consider for a larger surgery in that regard. Men one, clearly you have to remove. It's a very aggressive disease. Neonatal severe hyperparathyroidism, the most severe form, requires complete parathyroid removal and some autotransplantation. Men 2 is a milder form as far as the parathyroid is concerned. It is aggressive for adrenal, aggressive for thyroid, but then you just remove the part of it that becomes important. And carcinoma is a very, very rare thing. Think if the calcium levels are sky high, PTH is in hundreds, and there is a firm mass, then of course you have to manage that way in that perspective. So we'll start off with the cases, Dr.
So we have next case, 12 days old girl. She had irritability, dehydration. The serum calcium levels were very high, 18 milligram per deciliter. PTH was 300. Dr. Viva, what can be the possible diagnosis?
What is the phosphate value?
Phosphate is low.
Okay, so low phosphate, high calcium, and high PTH with a clinical feature of dehydration, irritability, giving us a clear diagnosis of hyperparathyroidism or increased PTH. Now, coming to the main important part is what is the fractional excretion to further confirm the diagnosis. So,
And if you consider it this age group, what do you think? A 12-day-old child?
so 12-year-old child,
12 day.
12 day, then this more of a hyperparathyroidism, because vitamin D deficiency won't cause this.
So this age group is extreme and the calcium is very high. So this is the most dreaded complication, most likely neonatal severe hyperparathyroidism. And urinary calcium to creatinine, Dr. Sandeep, was
It was
0.3.
0.3.
So in neonates, it may not be that high. So for that level of calcium, it's not high. So what are we thinking of?
Definitely, sir. Neonatal severe hyperparathyroidism in this case, and in this case we have to ask for the family what is the
Yeah,
calcium and the urine calcium. So as
Both parents had high calcium levels and low urinary calcium.
definitely this is homozygous
yes.
neonatal severe hypophosphatemia. The important
Yeah.
thing in this is the management part, because this is they present with a hypercalcemic crisis, and here we start with the saline diuresis with the 5 to 10 milligram per kg of furosemide, along with the this 0.9% of saline, that is 10 to 100 ml per kg. And the second option, we have a pimidone, or we can use zolintonic as well with a low dose like 0.01 to 5 milligram per kg, along with the paracetamol dose. And other options we have this salmon calcitonin, this calcitonin, which is given in this nasal puff. This is 5 to 10 microgram per kg per 12 hourly, but due to tachyphylaxis, it is not being very much used. Another very interesting thing we have is the cinacalcet. It is basically, it allostically modified the calcium sensing receptor and increases the binding of calcium to the calcium sensing receptor. In this way, decreases the calcium. So, and the next is the prednisolone. It inhibits the conversion of this activated vitamin D, so it decreases the absorption of calcium from the intestine as well as from the kidney. So these are the various options, and this has to be this case has to be managed very aggressively, because otherwise we can lose the.
So this is the most serious complication, probably endocrine emergency, I would say. We talk about DKA, we talk about hypoglycemia. They're much more easier to manage. This is the biggest challenge. You have to do everything. It's not just that you have given bisphosphonate, you have to give fluid, diuresis, steroids, everything is there in the armor. You may have to do dialysis also in that regards. Denosumab is a new agent. We haven't used it, but some people do mention that it may be a good agent, especially if the creatinine is high. But the neonatal age group, probably it's something which we have to worry. Ultimately, whatever you do, it's a temporary thing. You have to go for surgery in that regard. Dr. Hemchand, your experience in this condition?
I think it's a losing battle in most of the cases. Very, very aggressive tertiary care center management, and hit it like a nuclear war with all the armamentarium that is there, as it has been mentioned in this slide. And high risk consent must be taken, and the surgery is also a high risk procedure. We have to take a proper consent.
And I think I was discussing about breast milk hypernatremia, where sodium goes up to 180, 185. This is something like that. So it is like you have to do everything and still you may be losing the battle. So that is a problem. So surgery clearly is very, very important from there.
So neonatal severe hyperparathyroidism, it has a neonatal presentation. There is a family history of hypercalcemia, and
that was very important point raised by Dr. Vibha, that always check the parents. You may have hypercalcemia in the baby because of maternal hypoparathyroidism or maternal vitamin deficiency. Paradoxically, the calcium may go up. So that is absolutely important.
So we should check for the family history of hypercalcemia and hypocalciuria. Surgery is the mainstay treatment, and cinacalcet provides an interim relief. 21-day-old boy had irritability, mild dehydration, calcium was 14, PTH was 120. He was planned for surgery, but subsequently he was found to be improved.
So he was given those measures, but then he improved. So this is a very funny, the very interesting scenario, Dr. Hemchand. What
I think so. This is just a reflection of a continuum of the previous case, but with a milder phenotype.
Yeah.
If you see the calcium levels compared to the previous case, they are slightly lower here. The PTH level compared to the previous case, they are slightly lower here, and the dehydration is also mildly lower here. So this may be the one picture of the same spectrum of disorder on a milder form. And the interesting point to note is the urine calcium creatinine ratio. So this, whenever you have hypercalcemia and hypocalciuria, you know the culprit is probably the calcium sensing receptor. And this is a milder variant, which is a heterozygous presentation of the same genetic mutation, resulting in probably a benign self-limiting course importance of parental testing, genetic testing of the parent, and looking at the whole picture holistically is very important, is highlighted in this case.
So this is a very interesting scenario that father and the child both have a calcium sensing receptor defect. So the child is sensing mother's normal calcium is low. And because of that, there is a secondary response which is happening. This will improve over time. So not everybody will require surgery. So 20, definitely, but calcium 14 be a bit wary. Give some fluid, dehydration, maybe give a course of zolendronic acid, these things, then they may improve. So don't rush for surgery in that scenario. So this is self-resolving with paternal inheritance in that situation.
8 years old boy had abdominal pain, calcium of 12.2, phosphorus was low, 2.2, PTH was 60. He was planned for surgery. So, Dr. Vijay sir,
So I have to see the other, what I can see that there is of course high calcium and low phosphorus. So we have to see, and then PTS is about so a bit high. So before going surgery, we have to see that what other option that we have, whether we are dealing with spectrum disorder of say some familial hypercalcemia thing, or this is primary hyperparathyroidism. So two are the things, and to focus on approximately 2 3 important thing. One, what is the fractional excretion of calcium? What is the status of vitamin D? So these are the things what we have to see. So now coming again to PTH levels. So it is above 20 picogram per ml, and this fractional excretion of calcium is a bit low, that is in less than 1%. Then we have to see what is the status of vitamin D. So now this vitamin D is normal, then we have to think for calcium receptor defect.
I think the other very interesting thing which can be found is the magnesium level.
Yes.
Because in cases who have a calcium sensing receptor defect, it's not just the calcium which goes up, the magnesium will be on the higher side or normal, high normal side. While in hyperparathyroidism, your magnesium will go down. So that is another clue which was there in this case. So this was a calcium sensing receptor defect. If you do a surgery, if you remove the parathyroid, will you correct the hypercalcemia in this case?
no sir, because the
No.
sensing is also defective. So there will
So
be
urine will not be losing. So anyway, your calcium is not going to improve, and they don't require surgery. It's like a milder disorder.
So this was a case of benign.
And very importantly, they will not have renal calcification because you don't have hypercalciuria. Why are you worried about hyperparathyroidism? The first thing is kidneys. So this is not going to be affected in this case.
So this was the case of benign, familial benign hypercalcemia. It is a milder variant with no renal calcification, low urinary calcium, and high magnesium levels. So there is no role of surgery as such. Symptomatic treatment has to be given.
So we'll now move towards the last part, which is the low bone mass, which basically is a big topic in itself. But most cases that we're dealing with is either osteogenesis imperfecta, which is a problem in the collagen, its post-translational modification structure. So that is one group of disorder. The second most common will be drug-induced like steroids. So these are the most common ones, along with inflammatory disorders like arthritis. Many of these, hypogonadism and all those things, do have an issue, but they will improve once you correct the underlying cause, like anorexia nervosa, hyperthyroidism, hypogonadism, they will improve. So most commonly, we're talking about OI and the steroid-induced / immune disorders in which there are problems in that perspective. So we have discussed this in detail yesterday also. So it's not that osteoporosis is defined just based upon the BMD score. We are using the fracture, which is actually more important. So if now we should think of when to treat. Now these were the expert recommendations that suggested that if your bone density is more than -2, but there are spinal fractured, forget about the bone density. You would need treatment. If a child has clinically significant fracture with a Z-score less than -2, treatment is definitely indicated. But there are now other indications coming that if it is less than -2.5, even without fracture, you may consider treatment. So there has been some change in terms of the guidelines. And of course, if it's less than -2 and the pubertal decline in BMD Z-score is there, you may have to consider treatment. So you have to combine both Z-score, and Dr. Hemchand yesterday taught us very well as to how do we interpret the Z-score in terms of height, in terms of size, and other parameters. So you should do that exercise and look at the fractures are there or not. So most common option that we use is zoledronic acid. Pamidronate we are not using anymore. So zoledronic acid is highly potent. It basically has got predominant effect in the osteoclast. It's an anti-resorptive, long duration therapy. Remember to start at a very low dose, because if you give an anti-resorptive agent, you are depriving the body of calcium, and that may cause hypocalcemia in the initial phase. So start at a low dose and give it as an infusion. As Dr. Vibha was saying, fever is common, so maybe give some antipyretics as well. And acute phase reactions are common. So any infant, definitely OI, everybody who comes to us will require treatment. We remember the case we saw in the on-site also. This child has so much fractures and they will improve symptomatically. Now somebody presents to us later on with recurrent fracture or vertebral collapse. This is required. So indications are there. Very importantly, we also don't want to overdo. So now the guidelines are coming that you should monitor them on treatment as well. And if the Z score is going between -2 to 0, you'd make the dose half. So like hyperthyroidism, we talked about, you make the dose half when the thyroid is normal. If BMD is in the normal range, make it half. If the Z score is above the average, then make it even lower. So it is more likely to be 1/4 or even much lower dose from that perspective.
We had this 4-week-old girl. She had pain while handling and history of multiple and recurrent fractures. There was reduced bone density on X-ray. This is the X-ray suggestive of multiple fractures and low bone density. There was no family history of similar illness. So, Dr. Manoj,
Yeah, thank you very much. So here we are dealing with a 4-week-old girl who has a recurrent fracture. So first thing in the mind is coming like a pathological fractures. So there was no family history, but as seeing the picture and seeing the age specifically, I would like to have a thought about the OI in this perspective. And here the calcium and the phosphorus, calcium was normal, phosphorus was little bit high, alkaline phosphatase was high. So this is the diagnosis of the OI.
And how would you manage, Dr. Manoj?
Yeah, so here, as discussed, we can give the pramindronate or zoledronic acid. And here, while giving the pramindronate and zoledronic acid, we have to be worried about the pyrexia. And the dose, the initial loading dose will be milder than the thereafter dose. And here, we have to be worried about the acute phase reaction. And most importantly, before giving the any bisphosphonate, we have to supplement with the calciums and the vitamin D.
on follow-up, this patient was on zoledronic acid, 0.025 mg per kg per dose. Fever, she had fever initially, which was subsided with paracetamol, but subsequently she had seizures. So, Dr. Vibha, what could have been the reason?
Might be this seizures is due to hypercalcemia, because we have given the zoledronic acid and it has stopped the osteoclastic action, and the main calcium was coming from the bone, so that source has been stopped. So
And,
that
and the dose which was given was actually higher.
high.
We have mentioned much lower dose, 0.0125. So
Yes.
how is zoledronic acid available?
Sir, it is available as a vial, sir. It contains
How many milligrams?
4 milligrams.
4 milligrams. So when you say 0.0125 milligram per kg, that is infinitesimally small dose. So sometimes erroneously, whether the dose has been given wrongly, and even 0.025 is very, very high. So if you talk about 0.0125, how much dose would that be?
For this patient, it will be, I think, around
3 kg, 4 kg child. So it will be like a very, very
0.1.
small dose.
0.1.
So we have to be very cautious. 0.3, 0.4, that sort of a dose will be there. So this has to be very, very careful that they are not giving excessive dose, because then the hypocalcemia is universal then in that case. So Dr. Hemchand, you've got a lot of experience with OI. So what will be your take on this suggestion?
I think it's very important that the calcium supplementation is maintained and the calcium levels are monitored during treatment. And it's always better to have one person cross-verify the preparation by another person, and it should always be supervised by the physician and not just left to the staff nurse to administer zoledronic acid.
And even in this child, they are saying that they are much better. The child is able to sleep well. Otherwise, he was crying. So even though there is severe fracture, they will have symptomatic improvement early. So best is to start early, but even otherwise also, because they did not come for a long time, I
Yes,
think.
there was a loss of follow-up, sir. So on follow-up, 12 years, there was functional improvement. There was reduced fracture rate. BMD Z score has improved, and presently it is -1.6. So, Dr. Hemchandra sir, how will you further manage this case?
I think the improvement in the BMD Z score to a level that we need not label this child as osteoporosis just on the low bone mass based on the Z score value indicates that we'll have to do some amount of dose adjustments. So the dose adjustment can be in terms of the frequency, number one, or number two, it can be in terms of the quantum of the drug obtained. So a practical decision has to be made. These are the dosage adjustments that are recommended in the newer guidelines, where you reduce the dose by 25 or 50% based on the bone mineral density Z scores. And but same would be applicable to worsening of BMD also. You might have to escalate the doses in terms of, I think, the frequency. The escalation cannot exceed a ceiling limit. Irrespective of the fracture frequency, you cannot exceed 0.1 mg per kg per year. I think that is something we have to keep in mind. And if the fractures are fulminant despite such a high dose, then probably second line drugs, etc., may have to be considered, like denosumab, etc.
Do you have experience with denosumab yet?
Not in pediatric age group.
So there are a couple of studies in OI, but they are too early stages, I would say. And I think, Dr. Anshul, you have experience in denosumab in older individuals, in adults? Osteoporosis. So it's the best part of denosumab. It's a subcutaneous injection once in 6 months. It's easy. But the biggest problem with denosumab is that while zoledronic acid goes in the bone, stays there for a long time, denosumab is just a rank ligand inhibitor. The moment you stop it, its action goes off and the osteoclasts are waiting. So they will start eating up the bone. So you may develop very quickly, other problems will happen, and hypercalcemia, all those problems may develop suddenly. So this is something, so always you should have a plan B after you stop denosumab with what to shift on to, or you continue denosumab. That is the thing in that regards.
Sir,
Yeah, and when we stop the denosumab, that time the actually bone density declines.
Yes.
So it would be
because now they were sleeping, they were not dead. While zoledronic may kill them also. So that's the best part of zoledronic acid, best or worse, whatever you can say. What is the biggest problem of zoledronic in terms of the fracture? The problem is that the fracture will happen in unusual sites sometimes, because you have some areas which are very strong, some area which are weak. So you will have these bisphosphonate lines which are known, and even the shaft of femur, which is the strongest part of femur, you may have fracture. So everything you need to understand the problems in that.
so OI3 is a moderate to severe variant, presents with antenatal fractures. Multidisciplinary approach is important. Bisphosphonate long-term therapy is a key, and we should titrate the doses as per the BMD values. 10-year-old boy presented bone pain. There was a fracture on trivial trauma. It was a spinal fracture. Z score was minus 2.2 and was labeled as idiopathic juvenile osteoporosis. So, Dr. Vijay sir.
Yes. So this is a significant fracture because the patient is having a fracture with trivial fall, and sadly the spinal compression fracture is there. BMD jet score, if corrected, so I'm going to take that this is significant, and this is minus 2.2. So yes, so we can see here that blue sclera is visible again. So blue sclera is there. So this is OI, and that we have to, since there is significant fracture, so probably we have to think for zoledronic acid.
So I think the big other message is that just like CDGP,
Yes.
idiopathic, the term idiopathic should always raise your mind. What is idiopathic juvenile osteoporosis? Clinically examine to look for the various causes, and then only you will make a diagnosis. So it was there to be picked up. There was clear-cut blue sclera. So rather than just labeling idiopathic, we should try to make a diagnosis in that regard. We're not saying genetics in everybody, but otherwise you can make the diagnosis. This is OI1. And we will be treating, as Dr. Vijay said, that this is a clear-cut fracture. We should be treating in this regards.
So OI1 is a milder form. We should always differentiate it from the idiopathic form. We should always treat if there are significant fractures. 15-year-old boy, a case of juvenile chronic arthritis on long-term steroids. He had fragility fractures, and BMD Z score is minus 4.4. Testicular volume is prepubertal 2 mm, 2 cc, and bone age is 12 age. So, Dr. Manoj,
Yeah, so here there would be different case than we have discussed previously. That this is the pubertal boy who doesn't gain the puberty and has the chronic inflammatory conditions and taking the steroid. So here my thought process would be the is it really no, bone issue, primary bone issue, or is it a secondary issue? Here, according to the history, the boy is a prepubertal, so delayed puberty could be the reason, and patient was taking exogenous steroid that can weaken the bone more. So here the Dexascan would be guiding us for not to think about the primary causes of the deficiency rather than we have to think about the secondary causes. And this is the guideline that has been published by the American Society of the Rheumatologists. And here, with the fractures due to the glucocorticoid therapy, zolendronic acid or bisphosphonate would be very, very helpful. But along with that, we have to address the puberty and the growth deficiency issue here.
So very importantly, always be on calcium and vitamin D right at the beginning. And also consider measuring DEXA at baseline. That is something which is very important. If you're thinking of long-term steroids, a bone density should be considered at baseline. So
And
now,
Dexascan also we have to take as a pinch of salt in the pediatric age group because it should be validated by the pediatric software. In the many center, we don't have the pediatric software, so might be erroneously we are misdiagnosis the osteoporosis. So it should be corrected with the pediatric software. And here by the
so we
correcting,
took the help of Dr. Hemchand, and who gave that minus 4.4 was actually minus 2.8 in this case. But clearly, still there is a fracture. So this is very, very significant. Otherwise, then you have to give the bisphosphonate in this scenario. So again, we are moving towards not just wait and watch, but more towards treatment, because treatments are available, they are safe. When we can use it in an infant, what is the problem in a 15-year-old boy? We don't want them to develop spinal fractures. So be proactive, do DEXA at baseline, continue calcium, vitamin D, follow up DEXA, faltering, consider treating. And puberty, growth, all those things also become important.
So, glucocorticoids induce osteoporosis is important entity, and we should have a preventive approach. We should give calcium and vitamin to all, and we should monitor BMD at the initiation of treatment.